All right. Well, Dr. Wang, can you please introduce yourself? Tell us who you are, where you work, and what line of work you're doing.
Sure. My name is Doris Wang. I am a functional neurosurgeon at UCSF. I specialize in implanting DBS in patients with movement disorders and also treat them with ablative therapies.
Okay, great. And Dr. Ostrem, how about you?
Hi, yes. My name is Jill Ostrem. I'm a movement disorder specialist, and I've been working at UCSF now for about 19 years, and I help to direct the Movement Disorder Center there. And yeah, I've been involved with deep brain stimulation therapy for a long time.
Okay, great. And so it seems like you two work together quite often.
We do.
Yes, great. Well, I'm really excited to be able to have this conversation. We have so many people in our community interested in DBS and trying to understand what the process is like, and sort of that process between thinking about it and actually having it done. So, Dr. Ostrom, can you explain what DBS is for people who've never really don't know much about deep brain stimulation?
Sure. Yeah. And deep brain stimulation is a therapy that we can use to help people with movement disorders, and specifically in Parkinson's disease. It can be very useful in treating some of the motor problems that come, especially like more, after medications aren't covering the symptoms all the time throughout the day. And it involves placing an electrode into some of the motor nuclei in the brain, in deep structures of the brain. And it's connected to a battery that sits in the chest wall. The whole device is within the body. It's sort of like a brain pacemaker, if you can kind of imagine. And we can communicate with the device through the skin using our physician programmers and patient programmers. And we can adjust stimulation to kind of tailor the amount that's given for specific symptoms and for an individual patient's needs. It can have really powerful effects on some of the symptoms. So we're so lucky that we have this as a therapy we can offer patients, because it can really relieve a lot of suffering and improve quality of life.
Yeah. So what are some of the symptoms specifically that it helps the most with?
Yeah, so it can help a lot of the cardinal motor features of Parkinson's disease. So we talk about, rest tremor or even action tremor, but rest tremor is more classic. It can also help slowness of movement or bradykinesia. It improves rigidity, and it works kind of all the time, right? So because the energy is available to the brain to adjust the brain rhythms, it's kind of working for you all the time. So you don't have the ups and downs that you can get with medications as the medication is wearing off. With DBS, it's just kind of giving you consistent treatment of those things. And then the other thing it really can do is it can help dyskinesia, those involuntary movements that sometimes medications result, in Parkinson's over time. And people can take less medication, which is nice too. So things that it doesn't help as much are, cognition, which can be more of a later stage symptom sometimes for Parkinson's patients. It doesn't help, balance or freezing of gait very much. So those are some symptoms and a lot of the non-motor symptoms are not well treated. I mean, sometimes we'll see some improvement in things in those domains, but mostly it's there to treat the motor symptoms that I kind of mentioned.
Uh-huh. And if you said it doesn't help those, but are there things that it actually makes worse? We're going to talk a lot about like sort of the leads and where they could go, and how those are impacted. But Dr. Ostrom, are there things that it makes worse?
Well, if the deep brain stimulation electrode is not in the right place, that can lead to more problems. So you want to make sure that the stimulation is not also too high. So you want to keep the stimulation, the energy in the right area of the brain that's controlling the motor symptoms and not having it spread other places. And then I think there are situations where even if the electrode is placed ideally, you can still have sometimes some symptoms that that emerge that you want to address. But again, remember, deep brain stimulation is largely a reversible therapy. You can turn it off, you can adjust the stimulation, which is great. And so a lot of those unwanted symptoms that can happen but are more rare can be addressed by just changes in the settings often.
Okay. I would say that the most common symptom that people tell us get worse is their voice and speaking. That's pretty common?
Mhm. Yeah, so there are, depending on the target in the brain, you have speech fibers that can be nearby. And so if you have stimulation spreading into those speech fibers, sometimes you can have kind of a tight quality to your speech. But there are lots of issues with speech in Parkinson's disease. And so when people say their speech is worse, there's a lot to sort out. Maybe, people can even have problems with their speech just from disease progression. Hypophonia, real soft voice. That's a little bit different than when we have stimulation changes in affecting voice. So there's a lot we need to sort out. But you're right. I guess speech sometimes can be a little bit worse, and even for reasons we don't fully understand. But most of the time, if things are managed well, you don't have a lot of changes as a result of the stimulation or the surgery on speech, in my opinion.
Okay. And then I promise we'll get to you, Dr. Wang. The question about what makes a really good candidate for DBS. In the past, I think there was this idea that we're going to wait a little bit longer. What is the sort of standard these days in terms of maybe people with later onset Parkinson's and also YOPD, people with young onset Parkinson's? And in the past, it seems that it was always, you need to be responding well to carbidopa-levodopa, but it seems like that's not necessarily the case, especially with some YOPD people. So can you speak to those a little bit?
Well, candidacy for DBS is complicated, and it's really important that, when you're considering the surgery, that you work with a team that, is really experienced and can consider all the different factors that go into whether someone is a candidate for surgery or not. But you're right. I think we've been doing the surgery now a long time, and we have a lot more experience now to appreciate, who would really benefit, and also the side effects and complications of surgery are, have really gone down. It's a pretty safe surgery, so it's changed the risk benefit ratio, I think, over time. And but most people would still agree that if you're not having any disability or any motor fluctuations, you really don't need to think about DBS. We don't have any evidence to suggest it's neuroprotective yet or anything like that. Maybe we will, but we don't have that evidence right now. And so really it's when people have disability that is starting to build from, not being able to control their motor fluctuations. And, there's some issues with the medications, and that can be different for everyone. And, some people really don't tolerate medication very well, even if they get a great levodopa response. Perhaps they have other problems from levodopa, or just timing of the medication is difficult for them to remember. I mean, there can be lots of reasons why people don't want to rely only on the medication anymore to help their symptoms. Tremor is also a symptom that is, really responsive to DBS. And so some people have more tremor than others, and that tremor can be very difficult to completely treat with medication. And so sometimes that's another reason to go with an earlier surgery kind of plan, right? When the tremor is just really refractory. And then people that are younger who may inevitably get, motor fluctuation just because they're young and, it's coming eventually, why wait? There is kind of that sense of like, when you're younger, you'd be able to tolerate the surgery better anyway. But all these things need to be carefully considered and discussed with the team, and, make sure you have good family support and all of that. But yeah, there is a sense that, moving DBS earlier, in the kind of timeline of someone's experience with Parkinson's is the right thing to do.
Okay. And then is when somebody comes to you and they're a patient of yours and you've been treating them and you think it's time and maybe they should consider DBS, how much choice do they have in terms of what type of DBS device to get, what company to go for?
Yeah, I mean, the market is constantly changing. We're so lucky now to have all these different folks in the arena now with 3 different commercial devices, even just here in the US. And they're always changing the features and the equipment and, the device itself. So, Doris and I are always trying to stay up on like what we recommend, but, they're all really excellent systems. Certainly patients are aware of these different systems now too, and sometimes weigh in. There's a couple things that really help us, I think right now, is just whether someone is capable of recharging their device, or whether or not they would rather not have a rechargeable device and just get a battery replacement, in 2 to 3 years or something. So that helps us to kind of recommend what device sometimes we would go with. But patients are a part of the conversation too.
Mhm.
Mhm.
Okay. So Dr. Wang, about how many DBS surgeries have you done?
I actually just tallied it up this morning. So on my own, I've implanted about 150 new DBS implants, excluding battery changes and second stage surgeries.
Okay. And let's talk a little bit about Medtronic. So can you talk to us about them, about their devices, and why you believe in the efficacy of these devices?
Medtronic specifically.
Yes.
So yeah, they've been in the market for the longest time. And I would say, in the last 5 years, they're really coming up with really novel devices. One thing that's super exciting, I think, for both Dr. Ostrem, myself, and our center in general, is ability to actually sense and record brain activity besides just sending unilateral directional, stimulation to the brain. So in the past, DBS has always worked by just, sending constant stimulation. But as we know and learn more about the disease state, the brain is a shifting thing and it changes all the time. Symptoms fluctuate, depending on the medication cycle, depending on the time of the day. So sometimes a patient probably doesn't need as much stimulation. As Dr. Ostrom just mentioned, sometimes stimulation can lead to side effects, for instance. So it's really remarkable now we have the ability to actually listen to what the brain is doing and adjust stimulation based on the brain states.
What kind of battery does the Medtronic device use? And further than that, what is important for people with Parkinson's to know about batteries, like pros and cons, fixed, rechargeable, and replacing, and all that kind of thing?
Right. So besides, all these fancy features, I think one basic thing, as Dr. Ostrom mentioned, is whether a patient wants to deal with a rechargeable battery, which lasts 15 years, then it needs to be replaced, versus a non-rechargeable battery that lasts, depends on their stimulation setting, anywhere from, 2 years to maybe 5 years. And there are pros and cons to both. I would say, for somebody who's younger, probably a battery that lasts longer, so they don't need to come back as often for recharging or for battery replacement surgeries, that prevents infection and such, would be preferable. But then it takes more daily maintenance, right? So then that means they have to recharge their battery, make sure it's tanked up. And they do that, depending on their usage every day versus, a couple times a week. And that can be quite a burden on some patients. So in some of the other patients, if they don't want to have to deal with bring extra equipment with them when they travel, or dealing with the burden of recharging their device, then a non-rechargeable device would be preferable.
Okay. When they recharge it, can they be moving around as they're recharging it, or do they have to be sit still, tied up to something?
Yeah, so now they do have the wireless rechargeable, so they could theoretically move around. But the thing is, the battery, the charger has to be placed pretty much right above the battery to make sure there's good coupling, so they can't be, say, exercising, for instance. But yeah, they can sit around and watch TV and read while they're recharging their.
What is the difference, Dr. Wang, about with sleep and awake DBS? I think, when I interviewed people, even 5 years ago, it was almost everything was awake, but now more times it's happening to be asleep. So can you talk about the two differences there, and then why you would pick one over the other?
Absolutely. So awake surgery just means that patient, doesn't get general anesthesia, and that they're awake when we do testing and reporting. Asleep is done with patient under complete general anesthesia, so they don't need to participate in any part of the surgery or exam. In terms of, why we have better, I guess, asleep techniques now, is that we have all these great interventions and technology, allow us to visualize as the DBS lead is going to the brain. So we can take serial, almost real-time images in the MR magnet, for instance, to get super high accuracy. And in fact, the asleep MR guided surgery is more accurate compared to the awake surgery. So therefore, since we know where the lead is going to end up, then we don't need the patient to be awake and doing all the testing. And that really opens the door for a lot of patients who may have, qualms about being awake during surgery, who may be uncomfortable, just based on anxiety, fear of awake surgery. And thirdly, with awake surgery, we typically have patients come off of their medication because we want to see them kind of their most, I guess, the worst motor state. So then we can actually see the benefit of stimulation with our intraoperative testing. So for a lot of patients, that can be super uncomfortable because they're rigid, they may have painful dystonia, muscle cramping. So the sleep in that sense is really nice. They can still take their medicine basically right up upon the time they get surgery and restart it right after.
So if they do have to go off of it, is it many days before that they have to go off, or is it just 12 hours? Okay.
Usually 12 hours. And then I guess for some patients, they actually want to see the efficacy. So then for those patients, they prefer awake surgery. So we kind of, I kind of guide the patients just from my sense of whether somebody will be able to tolerate awake versus a sleep surgery. And a lot of it is also, patients are involved in that conversation and they'll let me know which method they prefer.
Yeah. What would you say your breakdown is at this point?
50-50. Slightly actually more awake than asleep, but and also depends on what I'm treating the patients for. So if I'm targeting deep nuclei for Parkinson's disease or dystonia, those are MR visible targets, so we can see really well. But for essential tremor, that nucleus is not really well visualized on typical MRI sequences. So for tremor, I do all those awake still.
Okay. So can you talk to us about what happens when the person comes into the hospital for the surgery that day? What actually happens to them? And can you talk a little bit about the different targets and what they help with and why you pick different targets?
Right. So by the time a patient is determined to be a candidate for surgery and, we book them for surgery, we've already decided on, the target based on our multidisciplinary discussion. So with, their treating movement disorder neurologists, taking into consideration their neuropsychological testing. Those are really important factors in determining target choice, GPI versus STM for Parkinson's. And then, and we also determine, whether based on patient preference and other factors, whether to do it asleep versus awake, because the workflow is very different. And then, and whether we do both leads in one surgery, so implant both sides in one surgery, or staging them. So implanting one side, let them recover a few months, and then come back and implant the second side later. So I guess once a patient comes in, they usually, go to preoperative area.
Actually, you mentioned it. Can we talk about the difference between if you're going to go awake or asleep and what the process is different? You just said
Right. So for awake surgery, I guess the difference is that I implant both the brain lead and the lead extension. So that's a connection wire and the battery all in one day. So they get all their hardware implanted in one day. So that's the main difference. Whereas the sleep surgery, because I'm operating inside a magnet, I can only have the right equipment to implant the brain lead for one surgery, and then they come back as an outpatient to get the connection wire and the battery in place. So the surgery is kind of split over 2 days.
Okay, so that might also be a reason that people might choose one over the other too, like to just let's just get it all done at once kind of thing.
Exactly. Yeah. So for patients traveling from far away, for instance, I see a higher preference for the awake procedure if they can tolerate it. Yeah. So yeah, that's another reason. And then in terms of, kind of hospitalization, patients typically stay, 1 night, maybe 2 nights in the hospital. With the asleep, because it's a shorter surgery and it's very minimally invasive and quick. Yeah, usually they get out by post-op day 1. And whereas the awake surgery, because they're awake for testing, there's usually more air entrapment in the brain, during the surgery. And because I'm doing more surgery, implanting other things that might slightly be more uncomfortable. Typically, I would say 2 days in the hospital. But otherwise, the recovery process is the same.
Uh-huh. And then, so Dr. Ostrom, I assume you are a part of the big team that is deciding what targets. So can you talk about the two targets for Parkinson's and why you pick one over the other? Or
Sure. Yeah, this has been a debate, for, I guess, since DBS was really around. I mean, so the Europeans would often implant the subthalamic nucleus, and then the US groups, started to advocate more for the globus pallidus as a target as well. But both targets really are very useful for treating the motor symptoms of Parkinson's disease. There's some subtle differences now that we appreciate across the two targets, after doing many, many studies for years. And the subthalamic nucleus, is a smaller nucleus in the brain, and there's other structures around it, so it tends to be there can be spread of stimulation outside of it, with some, more ease if you're not, really careful. And so sometimes people can have some behavioral changes or sometimes some cognitive changes with this nuclei implanted, especially people who are vulnerable. So, and also people who have a lot of significant motor fluctuations, who we call them brittle dyskinetics, where they, take just a half a dose of cinnamon and get dyskinesia, for example. The subthalamic nucleus, can sometimes be kind of a hot area where, stimulating there can be can generate dyskinesia, and so we sometimes don't want to implant in that kind of situation with the subthalamic nucleus. But it can really help people to lower medication, which is great. And I think there's like a lot of experience using that target and targeting that nuclei too with functional neurosurgeons. So it's a very good target. And then the globus pallidus, it's a larger brain structure. Like I said, it doesn't have quite as many, pathways right next to it that we can, affect. So, and we often don't have to reduce medication as much. It doesn't lead to dyskinesia as much when you stimulate in that area. So we sometimes will recommend that nuclei if someone is a little bit older, maybe, or who has some cognitive impairment, someone who has, a lot of dyskinesia, and someone who doesn't need to lower their medication as much, so then we might go with that nucleus. So, but it's always a conversation, and we, take into account, all the things that are important to having our neuropsychologist weigh in. Sometimes it's also, anatomically impossible to get to one of these nuclei because of some structural thing that Dr. Wang will show. There's just a vein in the way or something, wouldn't be safe. So all these things need to be considered to make recommendations to someone.
Mm-hmm. And Dr. Wang, do you think it's pretty split 50-50 in terms of the targets, or is there one target you tend to use more?
I think at our center, we tend to pick GPI as a target. I think it just based on our patient population. A lot of them tend to be older, have some of these comorbidities like mild cognitive impairment. So for the reason that Dr. Ostrem mentioned, I think we kind of lean towards GPI as a target.
It's so interesting you say that. I would not have said that we are that heavily leaning yet, but maybe we'll have to look at our numbers. Yeah.
Yeah, I was just looking at our GPI versus STN numbers.
Yeah. I mean, we're definitely, we definitely do implant a lot of GPI, but there's some, putting a younger person too, maybe we would also favor STN. So it just depends. Yeah.
Mm-hmm. And then how does your relationship work? Is it, you've decided, hey, I think this is a good thing to think about, the deep brain stimulation, Dr. Ostrom, and then the whole team comes together, Dr. Wang, you, the neuropsych, anybody, who else is on that team?
Yeah, we have a huge team. We're lucky at UCSF. We have, nurses that also help us in our pre-op assessment, who will do a lot of counseling with patients, who also do our on and off medication, motor assessments, and videotape them. We also have a lot of trainees that may have met the patient along the way, and so we like to include them in the conversation as well. Some programs will also include physical therapists or speech therapists, in their assessments. Usually we don't have as much input from them in our multidisciplinary meeting, but if they have seen them and we would read their notes, we could weigh in on that as well. And then we have a psychiatrist, which we're also fortunate to work with. So, if there's something psychiatric going on, then she would also be able to share what she thinks.
Mm-hmm.
And then after a patient finishes the whole evaluation process, we have a team conference where, every stakeholder, all the movement disorder neurologists, neurosurgeon, neuropsychologist, psychiatrist, all weigh in kind of on the final decision making.
What would you say, well, like when maybe it doesn't go the way the patient expected, what's normally going on when they, like, at the end of the day and a month later they come back and they're like, I wish I hadn't done this. This is not working. I don't like, what's going on usually?
Couple of things. First of all, we try to address making sure that our programming is optimized. And with DBS, you kind of hope for the slam dunk, but it may take several months, even up to a year, to get the full benefit and fine tuning. So we kind of work with them to see what aspect or symptoms that's bothering them, what can be treated. And one huge thing is about setting expectations. So during our preoperative evaluation, we try to be as honest as possible in guiding them. Okay, this aspect of your symptom is likely to improve with DBS and this is not. So to kind of avoid these disappointing outcomes in some aspects. And then I think also a patient's kind of neuropsychiatric state plays a huge role in this. So those are kind of my 2 cents.
Yeah, anything to add to that, Dr. Ostrem?
Yeah, I mean, I think it's fascinating just to appreciate this question, and I think the field is still not completely. We haven't really studied this that much, so kind of hearing from kind of our personal experience what it's like. But yeah, when people agree to have DBS, they often have high expectations. I think that this is going to really improve a lot of their symptoms. And so just like you were hearing, like we try to talk about beforehand what will be better and what may not get better. And some of we just don't know for sure what will for sure get better or not, or how much it will get better. But everyone still hopes that, they're going to feel a lot better. And because otherwise, to go through something like this, they are just expecting a lot. And so kind of trying to figure out like when you're optimized, when are you done adjusting the DBS, there's always something you can change and tweak and so you can get into a state where you're just always chronically unhappy because you're hoping for something more. So yeah, you really do need to work with people to communicate with what is realistic and when you're kind of pretty much there, so that people can just kind of also accept, this is my new normal, this is my new state, really, rather than continuing to just worry and think about, could I get another 1% better, right? So like I think that's something that the field hasn't really talked about, and now we have these new systems that are awesome and amazing. They can allow us to change stimulation in even more granular ways, but it also then people think, oh wow, I'm going to be even better now because I have this new device, or I have the adoptive DBS is coming and I'll be so much better. Maybe, but maybe not. So I think it isn't a cure. It is not a cure. And I think people sometimes think it's going to be, and the outcomes from DBS can be pretty different. So you can have someone who's really had an amazing change, right? And someone else who maybe didn't. And so it's just Parkinson's disease is not all one disease, it's different. And so, just because you talk to your one friend in your support group who had a great outcome doesn't mean you're going to have exactly the same experience. So a lot of this just needs to, a lot of time and counseling and being with people and explaining is really, really critical.
Yeah, I think that's definitely a frustration, right? Like somebody is like, oh my gosh, I was considered the perfect candidate. Everything was in line. This seemed to be the right thing. And they just are having a terrible time. I'm thinking of one person in particular. She's just 2 years out and it's just miserable.
Yeah.
But you did say that, this is reversible, right? So there is that option of just completely
correct
getting it off.
And there are some people who, it's sort of a different category, where where you really, are not getting the kind of outcome that you did expect, right? And so
Right.
that really makes you, really look back and say, okay, let's just double check here and make sure the electrodes are in the right place, that the programming is done correctly. Did we get the diagnosis right? I mean, sometimes that can be a factor. Are there any electrical issues with the system? This is when we get into troubleshooting. And so, when there are situations where something just doesn't quite line up with what we would expect, that does require a deeper dive into what's going on.
Yeah. So is there any difference between men and women with DBS? And either of you can answer this, like any difference in terms of their reaction to it?
I don't know, I could try to say, I mean, I think that that also has not been well studied. Women generally have smaller body mass, maybe more prone to dyskinesia. And they also, I think, are less likely to have DBS for reasons we don't fully understand. But there are more men with Parkinson's too. So there's all these things. I mean, I think just from the smaller body physicality, maybe there's some device considerations that go into that healing and things like that. I mean, Dr. Wang can comment. Mostly I just treat everyone, as much as I can as an individual.
Mm-hmm.
I agree. Yeah, I don't, see any major differences except for maybe the older women tend to have, thinner scalp skin. So, just smaller profile devices.
Right.
I would if they can tolerate rechargeable, I probably would urge them towards that. Again, it's agnostic to men or women, just anybody with thin skin and thin frame.
Yeah. So for both of you, for people who are watching this, what do you think is important for them to know about DBS?
I think that for the well-selected patients, and once you understand what the device can do and cannot do for you, it can be a really great life-changing therapy. And so I think you just need to find out more information about it from your neurologist and then go to an experience center to be evaluated. Those are my 2 cents.
Yeah.
Yeah, I mean, I agree. I think, we've come a long way. It's a very powerful therapy. And you can still manage, a lot of the other symptoms with medication as well, using in combination. And most people, I think that we see that we have implanted have not regretted having surgery. Almost everyone wishes they had done it earlier.
Yeah.
But you can't talk anyone into it. They have to be ready. And sometimes they have to, just have enough disability to get over the hump. But I just would really encourage people to find the right team that they feel comfortable working with, because you're going to be, followed now, after for management of the device for the rest of your life. And so you just want to make sure you've got a good team you're also working with. But, it's amazing. We still don't fully understand how this works, right? How it helps, but it is, probably beside levodopa, the greatest advance we've ever had in the field of Parkinson's disease therapy. So, it keeps getting better.
Well, I really appreciate you taking the time to talk to me today about this and our community. So many questions about DBS, and really just grateful to be able to share a lot of information from both sides of the operating room.
Great. You're welcome. Thank you.
Yeah.